Okay, let's unpack this. Today, we are undertaking, well, a massive deep dive. We're going straight into the source material to really master the surgical anatomy of the chest wall, the diaphragm, and the thoracic inlet. Our goal here is nothing short of achieving that elite level of comprehensive integrated knowledge, the kind professionals need when they're managing life and death situations inside this protective cage. We're not just listing structures. No, we're digging into the why, the developmental reasons, the navigational blueprints, and those really high-stakes procedural details.
Absolutely. That level of synthesis is, well, it's crucial here. The thorax, it's fundamentally defined by what's inside the heart, the great vessels, the lungs, and this incredibly complex musculoskeletal structure designed purely to protect them. So our deep dive today is all about connecting these dense anatomical facts to the clinical need. Things like managing trauma, both blunt and penetrating, correcting those congenital deformities, and of course, achieving safe, repeatable access to the organs inside for, say, tumor removal or cardiac surgery.
Right. So our blueprint for mastering this starts right at the beginning, how this cage is actually built embryologically. Then we'll move to the surface point surgeons use, to navigate. We'll trace every major nerve, artery, vein, and then bring it all together with advanced surgical techniques and trauma protocols. Let's kick off with embryology then, the original source of, well, both architectural success and sometimes failure.
Exactly. When a surgeon sees a congenital chest wall anomaly, their first thought really goes back to how it formed in the embryo.
Yeah.
Take the ribs. Their origin is very precise. They form from the costal processes of the thoracic vertebrae. And the source material really emphasizes that this development is tightly regulated by differential gene expression. Now, if that genetic blueprint gets disturbed, those costal processes might develop where they shouldn't. That's when you get the clinical headache of extra ribs, like a cervical rib popping up at C7 or a lumbar rib down at L1.
Yeah, and that cervical rib isn't just an extra bone, is it? It's often the culprit behind thoracic outlet syndrome, pressing on the brachial plexus or maybe the subclavian artery. It really shows how these minor developmental hiccups can cause major problems later on.
Precisely. And the sternum, that central anchor, it starts life completely different. It begins as these paired longitudinal strips of somatic mesoderm, kind of like cartilage bars. These then fuse in the midline. But crucially, they ossify segmentally. You can still see traces of this segmentation in the adult. The centers for the sternal body fuse together, but the center for the manubrium, it stays separate, forming that vital manubriosternal joint. That incomplete fusion is actually necessary for chest mechanics during breathing.
And the xiphoid process, that little bit at the bottom, that's a great example of developmental timing, right?
Yeah, it really is. The xiphoid is notoriously variable, and critically, it's one of the last bits of the anterior chest to turn to bone. It stays mostly cartilaginous until early adulthood, often only fusing well after birth. Why does that matter? Well, its perceived location changes over time, making it a bit of a dynamic reference point, not a fixed one. Okay, let's move down to the floor of the thorax, the diaphragm. Anatomically, it seems straightforward, but embryologically, it's quite complex, made from 4 main components.
That's right. 4 contributing sources. You've got the septum transversum, the mesentery of the esophagus, the pleuroperitoneal canal membranes, and then contributions from the lateral body wall. And the real aha moment for surgeons is realizing that a failure in one specific source leads to a predictable type of hernia. So if there's a problem with the closure from the pleuroperitoneal canal, you typically end up with a posterolateral defect. That's the classic spot for the most common congenital diaphragmatic hernia, the kind that often needs urgent surgery right after birth. And that structural development doesn't stop at birth, does it? It keeps changing, especially comparing a child's chest to an adult's. How does that difference impact breathing?
Yeah, the pediatric chest starts out pretty inefficient, mechanically speaking. At birth, the ribs are much more horizontal. They lack that downward slant you see in adults. Plus, the muscles are weaker. The result, babies breathe mostly with their abdomen. The chest wall itself doesn't do much expanding. As the child grows, the ribs become more oblique, gaining better leverage, and the muscles mature. That structural shift is what allows for effective, rib-driven breathing later on.
Speaking of ribs, let's just quickly nail down the classification. The true, false, floating.
Right. So true ribs are 1 through 7. They connect directly to the sternum via their own cartilage. False ribs are 8 through 12. Ribs 8, 9, and usually 10 attached to the cartilage of the rib above them. And then floating ribs are 11 and 12. They don't connect anteriorly at all. Surgeons really need to be aware of variations, though, especially the 10th rib. Sometimes it's floating, sometimes it connects. Our sources suggest that variability is pretty high, maybe 35% to even 70% floating.
Okay, and if you look at a typical rib, say of the kind a trauma surgeon encounters daily. What are the key bits they need to identify instantly?
Well, every typical rib has the main shaft, an anterior end for the cartilage, and a posterior end near the vertebra. Posteriorly, the head is key. It usually has two facets separated by a little crest that articulate with two different vertebral bodies. Then there's the neck, leading to the tubercle, which connects to the transverse process of the vertebra. And critically, on the inside surface of the shaft, that's where you find the costal groove. That's the channel housing the nerve, artery, and vein. And posteriorly, the way the ribs curve back creates that deep channel next to the spine, the paravertebral gutter. Very important space.
That mention of costal cartilage brings us neatly to pectus excavatum, the caved-in chest deformity. It's thought to be caused by cartilage overgrowth, but the timing of surgery is absolutely critical, isn't it?
Paramount. Yes, the mechanism seems to be that the costal cartilages grow too much, pushing the sternum inwards, but surgeons are very strict about delaying definitive correction until late adolescence or even early adulthood. The reason is purely mechanical. If you operate too early, while the chest is still growing rapidly, there's a high risk the deformity will just come back. And more seriously, you could end up restricting chest wall growth, a constrictive effect. You need that skeletal maturity for the repair to be stable and last.
Let's compare the two main surgical options, the open ravage and the minimally invasive NUS. Why does the hardware stay in so much longer with the NUS, 1 year versus, up to 4?
Good question. The ravage is the classic open approach. You make a midline sternal incision, you actually cut out the overgrown, deformed costal cartilages, reposition the sternum, and then put a metal bar or strut behind it to hold everything in place while it heals. Because you've physically removed the problem tissue and reconstructed it, the chest wall is stabilized pretty quickly. That strut only needs to stay in for about a year, minimum, to ensure solid bony healing.
Okay, and the NUS, that's quite different.
Totally different philosophy. The NUS relies on remodeling the existing cartilage through sustained pressure. You use 2 small incisions under the breasts, tunnel behind the sternum very carefully, and slide in a curved metal bar. It goes in with the convex side facing backwards, protecting the heart, and then with a quick controlled maneuver, you flip it 180 degrees so the convex side pushes the sternum outwards. But because you haven't cut out the cartilage, you're basically forcing it to remodel under this constant pressure. That takes time. So the bar has to stay in much longer, typically 2 to 4 years, to let the cartilage and bone fully set in that corrected position. Otherwise, it'll just spring back once the bar's out.
Right, that makes sense. Okay, let's shift to navigating the outside of the chest wall, the surface landmarks. You called the manubriosternal angle the master landmark.
It really is the angle of Louis. It's the absolute starting point for counting ribs accurately because it lines up with the second costal cartilage.
We know that, but what makes it so reliable, anatomically speaking?
Its reliability comes from being a true joint, a symphysis. Typically, that stays distinct throughout life. And it's usually easy to feel, often a bit more prominent in men. That horizontal plane passing through the angle, the sternal plane, is the traditional dividing line between the superior mediastinum above and the rest of the mediastinum below.
Okay, but this is where that critical clinical difference comes in, the one you mentioned earlier. Traditionally, we learned that key structures, tracheal bifurcation, aortic arch, azygos vein entry, all line up neatly at this T4, T5 vertebral level. But modern imaging tells a different story.
It does, and this has huge practical implications for surgeons and radiologists. While the bony angle itself generally lines up with the T4, T5 disc space, CT scans consistently show those 3 major soft tissue structures. The trachea splitting, the top of the aortic arch, and where the azygos vein joins the SVC are actually a bit lower, often more at the T5 or even T6 level. This changes your mental map when you're planning procedures based on surface landmarks. If you're aiming for something based on the traditional T4, T5 plane, like placing a tracheostomy or assessing tumor spread, you might actually be aiming too high relative to where those vital structures really are. So you absolutely rely on preoperative CT to confirm the exact level of those viscera before making decisions based solely on that T4, T5 landmark.
Okay, moving down from the angle, what about the xiphoid process and its joint, clinical use?
The xiphosternal joint, where the xiphoid meets the sternal body, is usually palpable down at the level of the 9th thoracic vertebra, T9. Its main utility is as a landmark for procedures needing access just below the sternum, like doing a subxiphoid pericardial drain, putting a needle into the pericardial sac to drain fluid. You need to know that T9 level to angle correctly towards the heart without hitting the lungs.
And posteriorly, what are the go-to points for finding specific vertebrae?
Posteriorly, the vertebra prominence, C7, is usually easy to feel, but the spinous process of T1 just below it is often very distinct too. For finding the lower ribs and vertebrae, a useful trick is to feel for the 12th rib laterally and trace it back and up towards the spine. That will lead you reliably to the T12 spinous process.
We definitely need to cover those immediate landmarks surgeons use constantly for drains, for incisions, the quick references.
Absolutely essential. The anterior and posterior axillary folds, those are formed by the edges of the pectoralis major and latissimus dorsi muscles. They basically define the safe zone, the armpit boundaries, for placing axillary ports during VATS or inserting chest drains laterally. And then the inferior angle, the bottom tip of the scapula, is crucial. If you trace its medial edge upwards, that's the classic landmark for finding the right level for a pleural tap, putting a needle in to drain fluid. And importantly, it helps plan the upper extent of a standard posterolateral thoracotomy incision, ensuring you're below the main bulk of the scapula.
We often describe the chest as this sort of irregular cylinder, bone and cartilage, kidney bean shaped in cross-section. Beyond protecting the heart and lungs, what else does it uniquely shield?
That's a key point. Its protective function extends down into the upper abdomen, thanks to how high the diaphragm domes up. The thoracic cage actually shields a large part of the liver under the right dome and the stomach and spleen under the left dome. And even the tops of the kidneys get some protection posteriorly. The right kidney sits behind the 12th rib and the left behind the 11th and 12th ribs. That broad, downward-sloping lower edge of the cage is vital abdominal protection.
The old historical procedure of thoracoplasty really hammers home how critical that bony support structure is.
It's a stark reminder, yeah. Thoracoplasty involves surgically removing ribs and cartilage. The goal was to deliberately collapse the chest wall down onto a lung that was destroyed by infection, like severe TB, to close off dead space. What it demonstrated brutally was that the ribs provide the essential rigid framework. That stiffness is necessary to maintain lung volume and allow for efficient breathing mechanics. Take away that bony support, and the chest wall just caves in. That's exactly why surgically fixing a flail chest, stabilizing those broken ribs, is now the standard of care to restore that framework.
That structure, though essential, can become a liability right at the top, the thoracic outlet, leading to thoracic outlet syndrome, or TOS. Can you explain the compression mechanism there?
Sure. TOS happens because the neurovascular bundle, that's the subclavian artery, the subclavian vein, and the brachial plexus nerves, gets squeezed as it passes through a very tight space. This space, the thoracic outlet, is bordered by the anterior scalene muscle in front, the middle scalene muscle behind, the clavicle above, and the first rib below. Not much room to maneuver. Symptoms usually involve pain, tingling, numbness, sometimes weakness in the arm and hand. We classify it based on what's being compressed. Neurogenic TOS, affecting the brachial plexus nerves, is by far the most common. Venous TOS and arterial TOS affecting the vessels are less common, but can be more urgent.
And the surgical fix for this involves working in that incredibly tight space. It sounds like anatomical hazards are almost unavoidable. What's the usual surgical approach, and what are the biggest dangers?
The standard approach is usually transaxillary, going through the armpit. The patient is positioned on their side. The surgeon makes a cut, typically transverse, between the edges of the pec major and la dorsi. Visibility in there is notoriously limited. You have to meticulously identify the brachial plexus and the subclavian artery. You carefully dissect and divide the scalene muscles, and then resect or remove the entire first rib. If there's a cervical rib present, that comes out too. The critical hazards, there are three big ones. The subclavian vein lies just anterior to the artery, and scalene's very vulnerable. The first thoracic nerve root, T1, which is part of the brachial plexus, is deep and posterior. And the pleura, the lung lining, is sitting right inferiorly, easily punctured.
You mentioned the scalenes and first rib. What about the long thoracic nerve? It runs right down the side there, supplying the serratus anterior muscle. How do surgeons protect that during a first rib resection?
Great point. Protecting the long thoracic nerve is absolutely paramount. It runs vertically down the side of the chest wall, often described poetically as on the serrated digitations like a spider on a wall. During a first rib resection, the surgeon has to specifically find it and gently peel it away posteriorly, keeping it out of harm's way. Often this means sacrificing a smaller sensory nerve, the intercostobrachial nerve from T2, which gives sensation to the armpit and inner arm. That's usually considered an acceptable trade-off because damaging the long thoracic nerve leads to winging of the scapula, a really debilitating functional problem due to paralysis of the serratus anterior.
Okay, let's move from the big extrinsic muscles to the intrinsic ones, the layers that actually make up the wall itself. The intercostal, subcostalis, transversus thoracis.
Right, the core layers. The external intercostals are the outermost muscle layer. There are 11 pairs. They run from the rib tubercle behind, almost to the cartilage in front, angling downwards and forwards, think hands in pockets direction. Anteriorly, near the sternum, they become a thin membrane, the external intercostal membrane. Deep to them are the internal intercostals. Again, 11 pairs. Their fibers run downwards and backwards, pretty much perpendicular to the externals. They extend from the sternum all the way back to the angle of the ribs posteriorly, where they become the internal intercostal membrane.
You mentioned earlier that the internal intercostals are thicker in one specific area. Why is that relevant?
Yes, they're noticeably thicker in the front part, between the cartilages, the intercartilaginous or peristernal part. That thickness matters because this is the part that's most active in pulling the ribs up during forced inhalation. When surgeons are making incisions or placing sutures in the anterior chest, they need to account for the density and function of this specific muscle portion.
And where does the transversus thoracis muscle fit in? Deepest layer.
Exactly. Transversus thoracis is the innermost layer, lying right on the internal surface of the anterior chest wall. It's kind of fan-shaped. It attaches from the lower sternum in xiphoid process and fans out to attach to the inner surfaces of costal cartilages 2 through 6, roughly. What's anatomically interesting is that its lowest fibers often blend right in with the uppermost fibers of the transversus abdominis muscle in the abdominal wall. It shows that fundamental continuity between the thoracic and abdominal wall musculature.
Let's revisit that specialized surgical application you touched on, the intercostal muscle graft.
Ah, yes, it's a really neat example of using segmental anatomy. Each intercostal muscle gets its own reliable blood supply from its corresponding posterior intercostal artery. This means you can carefully dissect out a segment of intercostal muscle, keeping its artery intact like a leash of pedicle, and then rotate that living muscle flap to cover or reinforce something nearby. It's classic use. Reinforcing a bronchial anastomosis, the suture line where you've reconnected an airway, say after removing a lung lobe, lobectomy, or even a sleeve of airway. That airway suture line can be fragile, prone to leaking. Wrapping it with a well-vascularized intercostal muscle flap provides extra tissue, brings in blood supply, and really helps promote robust healing, reducing the risk of a dangerous air leak.
Okay, blood supply. The arterial system sounds like a neat dual supply setup, front and back.
It is quite elegant. It's segmental, with contributions from both anterior and posterior sources. Anteriorly, the main players are the internal thoracic artery, also called internal mammary artery, or IMA, running down either side of the sternum and its branch, the musculophrenic artery. Together, they give off paired anterior intercostal arteries for the upper 9 spaces. These anterior vessels run forward in the spaces and eventually meet up, or anastomose, with the posterior supply.
And the posterior supply comes from?
Directly from the major systemic vessels. For the top 2 spaces, first and second, the supply comes from the superior intercostal artery, which is a branch of the costocervical trunk coming off the subclavian artery. Then for the next 7 spaces, T3 down to T9, large single posterior intercostal arteries branch directly off the back of the descending thoracic aorta. These are the dominant supply to the spaces.
Now, the venous drainage, especially on the left side, sounds much less straightforward, more like complex plumbing, the azygos system.
That's a perfect description. The venous drainage via the azygos system is notoriously variable, particularly on the left, and you absolutely need to have a map in your head. Okay, so anteriorly, it's simple enough. The anterior intercostal veins drain into the internal thoracic veins, which then drain upwards into the brachiocephalic veins in the neck. Posteriorly, on the right side, it's also fairly consistent. Most of the posterior intercostal veins drain directly into the large azygos vein, which runs up along the right side of the vertebrae and arches over the lung root to empty into the back of the superior vena cava, SVC.
But the left side is where the hemiagus system comes in, creating those multiple pathways.
Exactly. The left side is where it gets complicated. It uses 3 main routes to eventually get blood back to the SVC, usually via the azygos vein. First, the very top veins, usually T1, T2, maybe T3, form a left superior intercostal vein. This often drains upwards into the left brachiocephalic vein by passing the azygos system entirely. Then, the mid-thoracic veins, roughly spaces T4 down to T7 or T8, collect into the superior hemiazygos vein, also called accessory hemiazygos. And the lower veins, T8 or T9 down to T11, collect into the inferior hemiazygos vein. Now, both of these hemiazygos veins, the superior and inferior, typically have to cross the midline behind the aorta, usually around the T8 or T9 level, to empty into the azygos vein on the right side.
So what are the clinical implications of all that left-sided venous variability? Why does a surgeon need to know this complex map?
It's critical for a few reasons. First, central venous access. If you're placing lines, you need to be aware of these large cross-connections. Second, mediastinal surgery or tumor involvement. If a surgeon is working in the left mediastinum, especially superiorly, they must know about that left superior intercostal vein draining directly into the brachiocephalic injury that is a major bleed. Also, the hemiazygos veins crossing the midline are often the first structures to show signs of trouble, like getting enlarged or pushed aside if there's a tumor invading the posterior mediastinum, or if there's blockage in the central thoracic lymph nodes or the azygos system itself. Their appearance on imaging can be a key diagnostic clue.
Okay, let's switch to nerves. Innervation seems more straightforwardly segmental in the thorax compared to, say, the limbs with their complex plexuses.
It is, largely. The ventral ramies, the main front branches of the 12 pairs of thoracic spinal nerves, mostly stick to their own segment. They don't mix and mingle quite as much as the cervical or lumbar nerves do in forming the brachial and lumbosacral plexuses.
T1 is the exception, though, right? It mainly goes to the arm.
Correct. The majority of the T1 ventral ramus dives up and contributes significantly to the brachial plexus, supplying the arm muscles. T2, T3, and T4 mostly supply the chest wall itself, the intercostal muscles in the skin over that segment, the dermatome. But then it gets interesting again with T5 down through T11. These intercostal nerves continue running forward and downward, and they supply not only the lower thoracic wall, but also the muscles and skin of the abdominal wall. That segmental overlap is why shingles pain from a thoracic nerve root can often wrap around onto the abdomen, and it's why an intercostal nerve block for rib fracture pain works well, but only for that specific nerve's territory.
You mentioned a couple of specific nerves earlier that deserve highlighting again.
Definitely. We have to re-emphasize the long thoracic nerve. It comes from C5, C6, and C7 nerve roots way up in the neck, travels down, and runs along the side of the chest wall on the serratus anterior muscle. We already talked about protecting it during axillary surgery or first rib resection, because damaging it causes that disabling winged scapula. Then there's the intercostobrachial nerve. This is usually the lateral cutaneous branch of the second intercostal nerve, T2. It punches out laterally, crosses the axilla, and provides sensation to the skin of the armpit and the upper inner part of the arm. It's very commonly encountered and often deliberately sacrificed during axillary lymph node dissection or breast surgery, leading to numbness in that area, which patients need to be warned about. It's sensory only, though, so no major motor loss.
Okay, rounding out innervation. The autonomics. The sympathetic and parasympathetic systems controlling the internal organs.
Right, the involuntary stuff. The sympathetic trunks are those chains of ganglia, like beads on a string, running vertically down on either side of the vertebral bodies, sitting right on the heads of the ribs posteriorly. They get input from preganglionic nerve fibers originating in the spinal cord from T1 down to L2. These fibers enter the sympathetic chain. Now here's a key surgical point. Some preganglionic fibers synapse right there in the ganglion at the same level. Others travel up or down the chain before synapsing. But critically, many fibers originating from T5 down to T12 don't synapse in the thoracic chain at all. Instead, they pass straight through, bugle together to form the thoracic spranchnic nerves, greater, lesser, least, pierce the diaphragm, and travel down into the abdomen to synapse in prevertebral ganglia there, like the celiac ganglion of the aorta, or even go directly to the adrenal medulla. This pathway controls gut motility, vessel tone, and adrenal function.
And the parasympathetic side in the chest is dominated by the vagus nerve.
Entirely. The vagus nerve, cranial nerve X, originates way up in the brainstem medulla. It travels down through the neck and into the thorax, where it branches extensively to form nerve plexuses around the lungs, pulmonary plexus, heart, cardiac plexus, and esophagus, esophageal plexus. Its functions are generally opposite to the sympathetic system in the chest. It's the main bronchoconstrictor. It narrows the airways by acting on smooth muscle. And it's secretomotor. It stimulates mucus gland secretion in the airways.
Okay, let's focus now on the diaphragm itself, that elegant domed muscle separating the chest from the abdomen. You mentioned its position is highly variable clinically.
Extremely variable. It's this big, musculofibrous sheet muscle around the edges, central tendon in the middle. It's convex on the top side facing the lungs, concave underneath facing the abdominal organs. But exactly how high it sits depends massively on someone's body shape. It tends to be higher in shorter, heavier individuals. Posture matters. And, critically, the state of the lungs. Normally, the right dome sits higher than the left because of the liver underneath it. On expiration, the right dome might reach the level of the fourth costal cartilage anteriorly, roughly nipple level.
And the movement during breathing is quite dramatic, isn't it?
It really is. On a full, deep breath in, The domes contract and flatten, pulling downwards. They can descend by as much as 10 centimeters, significantly increasing the vertical volume of the chest cavity. Conversely, in diseases like severe emphysema, where the lungs are overinflated and lose their elastic recoil, the diaphragm gets pushed down permanently. It becomes flattened and much less efficient as a muscle of respiration, forcing the person to rely heavily on their neck and accessory muscles to breathe.
We touched on the blood supply being rich superior and inferior phrenic arteries, branches from intercostals. Let's re-emphasize the innervation, specifically that split between motor and sensory. That seems key.
It's absolute key to understanding diaphragmatic problems. The motor supply, the nerve signals telling the muscle to contract, comes entirely from the two phrenic nerves. Remember the mnemonic, C3, 4, 5, keep the diaphragm alive. This is why a high spinal cord injury above the C3 level results in diaphragmatic paralysis and the need for mechanical ventilation. Below C5, phrenic function is usually spared, but the sensory supply feeling pain or stretch is split. The central part of the diaphragm, including the pleura covering its top surface and the peritoneum covering its bottom surface, gets its sensation from the phrenic nerve. This is why irritation of the central diaphragm, like blood or infection, often causes referred pain felt up in the shoulder tip, because the C3, 4, 5 nerve roots also supply sensation to the shoulder area. However, the peripheral outer rim of the diaphragm gets its sensation from the lower 6 or 7 intercostal nerves. This dual sensory innervation is really important for diagnosing pain and planning pain management, especially after surgery or trauma involving the diaphragm.
Okay, the diaphragm isn't solid. It has crucial openings, apertures, for structures passing between the thorax and abdomen. Let's precisely locate the big three, starting with the lowest one.
Right. Lowest and most posterior is the aortic hiatus. It sits right against the vertebral bodies, typically at the level of the T12 vertebra. It's really more of a gap behind the diaphragm's posterior attachments than a true hole through the muscle. It transmits the descending aorta, the thoracic duct, the main lymph channel, associated lymphatic trunks, and sometimes the azygos and hemizygos veins slip through here too.
Okay, moving up and slightly forward from there.
Next up is the esophageal hiatus. This one is a true hole through the muscular part of the diaphragm, specifically through the right crus. It's located higher than the aortic opening, usually around the T10 vertebral level, and sits a bit anterior and to the left of the aortic hiatus. It transmits, obviously, the esophagus itself, along with the anterior and posterior vagal trunks, which become the gastric nerves supplying the stomach, and small esophageal branches of the left gastric artery and vein traveling up from the abdomen. Because this hiatus is muscular, it acts like a sphincter. But it's also a common weak spot, the site where stomach can protrude upwards into the chest, causing a hiatal hernia.
And the highest of the three major openings, the caval opening. What's its unique physiological role?
The caval opening is the most superior, situated in the central tendon of the diaphragm, not the muscle. It's typically found around the level of the T8-T9 intervertebral disc. It's somewhat quadrilateral or star-shaped. It transmits the inferior vena cava, IVC, the large vein bringing blood back from the lower body. Crucially, the wall of the IVC actually adheres firmly to the fibrous margins of this opening. It also allows passage for some terminal branches of the right phrenic nerve. Its unique physiological role relates to breathing. When you inhale, the diaphragm contracts and descends, pulling on the central tendon. This action actually widens the caval opening. At the same time, the increased abdominal pressure and decreased thoracic pressure help suck venous blood up from the abdominal IVC into the thoracic IVC and right atrium, significantly boosting venous return to the heart during inspiration.
Besides those big three, there are smaller passages and potential weak spots we should mention.
Yes, a few lesser apertures and spaces. The splanchnic nerves, greater and lesser, we mentioned earlier, usually pierce the muscular crura of the diaphragm on the way to the abdomen. The sympathetic trunks typically pass behind the diaphragm altogether, deep to the medial arcuate ligaments, which arch over the psoas muscles. Then there are two key potential weak spots, areas where muscle is thin or replaced by looser connective tissue called areolar tissue. One is a small gap between the sternal attachment and the costal attachments anteriorly, called the foramen of Morgagni. The superior epigastric vessels pass through here. Hernias can occur here, though they're less common. The other, perhaps more clinically relevant, is posteriorly and laterally between the costal muscle attachments and the lateral arcuate ligament, which arches over quadratus lumborum. It's called the foramen of Bacalec. In this area, the back of the kidney is separated from the pleural cavity above by only this thin layer of areolar tissue and the diaphragmatic fascia. This creates a potential pathway for infection to spread between the perinephric space around the kidney and the pleural space in the chest.
Okay, let's apply all this anatomy directly to surgical procedures and safety. Starting with something common. Inserting an intercostal chest sprain. The absolute rule is to go just above the lower rib of the chosen space, right?
That is the fundamental SACE principle, non-negotiable. The aim is always to avoid damaging the intercostal neurovascular bundle, the vein, artery, and nerve van, which runs snugly in the costal groove along the inferior border of the rib above the space you're entering. So by aiming your needle or trocar just over the superior border of the rib below, you maximize your distance from that bundle tucked under the rib above.
But you flagged a critical warning earlier, that costal groove protection isn't guaranteed everywhere.
Yes, and this is a detail that absolutely defines expert anatomical knowledge versus just reciting the rule. That protective costal groove, sheltering the bundle, is really only reliable on the anterior and lateral aspects of the rib. Posteriorly, near the rib angle and back towards the vertebrae, the bundle often leaves the groove and lies more directly between the internal and innermost intercostal muscle layers in the middle of the space. It's much less protected back there. Therefore, inserting a chest drain posteriorly carries a significantly higher risk of directly injuring the intercostal nerve, causing chronic pain, or the artery vein, causing serious bleeding. That's why the preferred insertion site is usually more anterolateral.
And to find that preferred site safely, surgeons use the triangle of safety. Can you map out its borders precisely for us?
Sure. The triangle of safety is that anatomical sweet spot in the axilla, generally considered the safest place for chest drain insertion. Its boundaries are anteriorly, the lateral border of the pectoralis major muscle, posteriorly, the lateral border of the latissimus dorsi muscle, inferiorly, a horizontal line at the level of the nipple, roughly the fifth intercostal space, and the apex points up into the axilla. The rationale is clear. Going through this triangle minimizes the amount of muscle you have to traverse, reducing pain and resistance, and it avoids major nerves like the long thoracic and thoracodorsal nerves, as well as major vessels.
Even with protocols, horrific complications can happen, particularly involving the heart. What patient factors really increase that risk of accidentally sticking the drain into a cardiac chamber?
The absolute nightmare scenario is inadvertent insertion into the heart itself, usually the right atrium or the right ventricle anteriorly or the left ventricle laterally. The risk of this catastrophic event is dramatically increased by a couple of key factors. First, patient build. In very thin or cachectic patients, the distance from skin to heart is minimal, reducing any safety margin. Second, and perhaps more common, is underlying cardiac chamber enlargement. If a patient has, say, severe cardiomyopathy causing a massively dilated left ventricle or significant right heart enlargement, the heart can bulge right up against the chest wall, particularly anterolaterally. In these cases, even a correctly placed drain according to surface landmarks could potentially enter the heart. Pre-procedural imaging review is vital in these patients.
Okay, moving to major access for lung surgery. The workhorse approach has always been the posterolateral thoracotomy.
Still considered the gold standard for maximal exposure, yes. Safest and most effective for complex lung resections or accessing the esophagus high up.
Can you walk us through the classic incision planning for that? You mentioned 3 key marks the surgeon makes with the patient positioned on their side.
Right. Patient positioning is key, lateral, decubitus, arms supported out of the way. Then the marking ensures the incision is placed optimally. Mark 1. Usually placed about 1 finger's breadth below the inferior tip of the scapula. This marks the lower end. Mark 2. This defines the posterior extent. Find the midpoint between the scapula's vertebral border and the line of the spinous processes, then go about 3 finger breadths above the level of the scapular tip. Mark 3. This marks the anterior extent. It runs downwards and forwards towards the front, aiming below the nipple line for most lung work, or perhaps angled more towards the costal margin if you need lower esophageal or diaphragmatic access. Connecting these marks gives you that classic curved posterolateral incision.
And which major muscles have to be divided? And what's the key nerve you have to protect during that muscle division?
To get down to the ribs, you inevitably have to divide some big important muscles. The latissimus dorsi is almost always divided posteriorly. It's very thick and vascular, so careful biothermy, cautery, is mandatory. The scapula is then retracted upwards. Often the lower portion of the trapezius muscle might be incised posteriorly as well. Anteriorly, the serratus anterior muscle usually needs to be divided to allow the ribs to spread adequately. The critical point here is to divide the serratus inferiorly. You must preserve its upper attachments and, crucially, protect the long thoracic nerve which runs down its outer surface, supplying it from above. Damaging that nerve, as we said, leads to winged scapula. Once the muscles are divided, you typically enter the chest cavity through the 4th or 5th intercostal space.
But the trend now is strongly towards minimally invasive VATS, video-assisted thoracoscopic surgery.
Definitely. Less pain, faster recovery.
Can you describe the typical port placement for a standard anterior VATS approach?
Yes, the anterior approach is common, especially for lobectomies. It usually involves three main ports, though variations exist. The main working port, the utility incision, is often slightly larger, maybe 3 to 5 centimeters. It's typically placed in the third or fourth intercostal space, in that triangle of safety area we discussed, between the latissimus dorsi behind and pec major in front. The camera port is usually placed lower and more posterior, perhaps in the sixth or seventh space in the mid-axillary line to give a good panoramic view. And then an instrument port is often placed more posteriorly, maybe below the tip of the scapula, for retracting lung tissue or passing instruments. But this is just a template. The surgeon will always tailor the port placement based on the exact location of the tumor or lesion they're targeting and the patient's individual anatomy, considering the heart and diaphragm positions.
Let's switch focus to the heart and great vessels. For most major cardiac operations, the default access is still the median sternotomy, splitting the breastbone down the middle. Beyond the bone, what's the immediate structure you encounter right behind it?
The incision runs right down the midline, from the suprasternal notch at the top to the xiphoid process at the bottom. Once the sternum is divided, usually with a saw, the immediate risks are the pleural reflections. Especially higher up near the manubrium, the two pleural sacs can come very close or even overlap in the midline. You have to be careful not to open them unless intended. Directly behind the sternum, in the anterior mediastinum, lies the thymus gland, or its fatty remnant in adults. And deeper still, you encounter the pericardium covering the heart and the ascending aorta.
And we can't talk sternotomy without mentioning the internal thoracic artery again. Its location is critical.
Absolutely critical. The ITA, or IMA, is the premier conduit for coronary artery bypass grafting, CABG, especially the left ITA, to the LAD artery. Surgeons harvesting it must remember it runs vertically down, roughly a centimeter or a finger's breadth lateral to the edge of the sternum, deep to the intercostal muscles. Protecting the contralateral ITA during sternotomy and carefully harvesting the graft IPA without damaging it is a core skill in cardiac surgery.
The push towards minimally invasive cardiac surgery, MICS, aims to avoid the full sternotomy. But you flagged a significant risk, iatrogenic nerve pain.
Yes, it's a real concern with MICS. Because you're working through much smaller incisions, maybe a partial sternotomy or just an intercostal space, you need retractors to open up that limited view. If you use rigid metal retractors and crank them open forcefully to see, you can easily crush or stretch the intercostal nerves running in that space. This can lead to severe, persistent postoperative pain, iatrogenic neuralgia, which can sometimes be worse than the pain of a full sternotomy. So MICS surgeons are very mindful of this. They use specialized soft tissue retractors where possible, limit the force and duration of retraction, and are meticulous about nerve protection.
How would a surgeon typically approach the aortic valve using a MICS technique?
There are two main MICS approaches for the aortic valve. One is a partial upper sternotomy. Here you only divide the top part of the sternum from the suprasternal notch down to maybe the second or third intercostal space, often making a J or T shape cut extending into the right interspace. You have to be very careful to stay lateral to the right internal thoracic artery when making that transverse cut. The other option is a right anterior thoracotomy, usually through the second or third intercostal space. This involves a small, maybe 5 to 7 centimeter incision on the front of the right chest. However, this approach is only really feasible if preoperative CT scanning confirms that the patient's ascending aorta is positioned centrally or slightly towards the right side. If it's deviated left, access is impossible this way.
And you mentioned sutureless valves earlier. How do they specifically help in MICS aortic valve replacement?
They're a game changer for MICS AVR. The hardest part of replacing an aortic valve through a small incision is securely sewing the new valve prosthesis into the aortic annulus deep down in the chest. It requires long instruments, precise stitching, and it takes time. Sutureless valves, or rapid deployment valves, are designed to be positioned in the annulus and then deployed. They often have a self-expanding frame or require just a few guiding sutures. This dramatically reduces the time needed to implant the valve, shortening the period the patient is on cardiopulmonary bypass, the cross-clamp time, which is directly linked to better outcomes and faster recovery. It makes MICS AVR feasible for more patients.
Okay, and for the mitral valve, typically on the left side of the heart, which space is preferred for MICS?
For MICS mitral valve surgery, the approach is usually via a right thoracotomy, typically through the fourth or fifth intercostal space. An incision is often placed just under the breast crease submammary in women for better cosmesis, or maybe a semicircular incision around the areola in men. This provides direct line-of-sight access across the right atrium to the mitral valve.
Finally, accessing the mediastinum itself, maybe for lymph node biopsy or staging, how do surgeons get to those pretracheal nodes high up?
For the superior mediastinal nodes, particularly those around the trachea, aratracheal nodes, the standard approach is a cervical mediastinoscopy. This uses a small horizontal incision just above the suprasternal notch in the neck, similar to a thyroidectomy incision. The surgeon dissects down behind the strap muscles, enters the pretracheal fascia, and then uses a special scope, mediastinoscope, and long instruments to carefully dissect and biopsy nodes along the trachea. The main hazard here, especially in children where structures are higher, is the brachiocephalic innominate artery, which crosses obliquely in front of the trachea high up. Blind or overly aggressive dissection risks catastrophic hemorrhage.
And for nodes a bit lower down, say in the aorta-pulmonary window between the aorta and pulmonary artery.
For those nodes, which are inaccessible via the cervical route, an anterior mediastinotomy, sometimes called the Chamberlain procedure, might be used. This usually involves a small transverse incision over the second or third intercostal space, typically on the left side. The surgeon divides the intercostal muscles to enter the mediastinum just lateral to the sternum. The key hazard here is the internal thoracic artery and vein, running vertically just deep to the costal cartilages. These vessels almost always need to be carefully identified, ligated, and divided to allow safe access into the anterior mediastinum to reach those nodes.
Okay, let's pivot to trauma. Rib fractures are incredibly common in blunt trauma, but their morbidity, the complications they cause, is often underestimated, isn't it?
Hugely underestimated. Rib fractures are everywhere in trauma centers. But the statistic that really stands out from the source material is that about 1/3 of patients admitted to hospital with rib fractures go on to develop serious complications, typically hospital-acquired pneumonia or even respiratory failure requiring ventilation. And it's often the sharp, broken ends of the ribs themselves that puncture or contuse the underlying lung, causing the initial injury. When you have multiple ribs broken in 2 or more places, you get that dreaded flail chest segment. It moves paradoxically, sucks in when you try to breathe in, pushes out when you breathe out, completely disrupting normal breathing mechanics and often leading directly to respiratory failure.
The thinking on managing flail chests underwent a major shift about 20 years ago, moving away from just supportive care towards surgical fixation. What did the evidence show?
Yes, those randomized controlled trials were pivotal. They definitively showed that surgical stabilization of rib fractures, SSRF, for flail chest provides significantly better outcomes compared to the old standard of just internal splinting with positive pressure ventilation. Specifically, patients who got surgical fixation spent less time in the ICU, needed fewer days on the mechanical ventilator, and had better long-term pulmonary function and less chronic pain. The impact on disability is also striking. The data suggests patients managed conservatively lose, on average, around 70 days of work or normal function. Fixation gets them back on their feet faster.
So for the elite trauma surgeon deciding to operate, the pre-op planning sounds incredibly complex. It's not just about fixing bones, it's a balancing act. What are they juggling?
It's a multifaceted decision process. 4 key things they have to balance. 1. Incision planning. How do you design an incision, or maybe multiple incisions, to get access to the maximum number of fractured ribs needing fixation, while doing the least amount of damage to the overlying muscles, especially the crucial shoulder girdle muscles? 2. Hardware selection. Ribs have notoriously thin cortex, especially in older patients. You need specialized plating systems, low-profile plates, locking screws that can get adequate purchase without cracking the bone further. 3. Concomitant injuries. Often the patient also has a lung laceration that needs repair, or maybe a diaphragmatic rupture. The surgeon needs to plan the approach to allow for fixing the ribs and addressing these other injuries simultaneously. 4. Single versus multiple incisions. Do you make one long look and fix incision, or use smaller incisions directly over fracture clusters, maybe connecting them by tunneling under the muscle? Each has pros and cons regarding exposure versus morbidity.
Let's break down the common surgical approaches for fixation, starting anteriorly for sternal or costal cartilage fractures.
Right. If the sternum itself, or the manubrium, or the costal cartilages of the upper ribs, say 2 through 7, are fractured and displaced, you need an anterior approach. This usually involves a midline incision, similar to a sternotomy, directly over the sternum. To get exposure to the fractured cartilages laterally, the surgeon typically needs to retract the pectoralis major muscle. Sometimes, for extensive fractures, the entire pec major origin might need to be carefully elevated off the chest wall as a flap to allow plating of the underlying cartilage and ribs.
Okay, what about the more common fractures out laterally on the sides of the ribs, often from direct impact? How do surgeons approach those while trying to protect the big muscles?
For fractures involving the mid-shaft of ribs 3 through 9, a lateral approach is typically used. The incision is usually placed directly over the main cluster of fractures. The absolute priority here is muscle preservation. You want to avoid cutting through the latissimus dorsi, the trapezius, and the serratus anterior if at all possible, because damaging these significantly impacts shoulder function and long-term recovery. Muscle-sparing techniques are key. This might involve carefully splitting muscle fibers rather than cutting across them, or mobilizing a muscle like the serratus anterior by detaching its lower edge, rolling it out of the way to fix the ribs underneath, and then securely reattaching it at the end. Protecting the nerve supply to these muscles is paramount.
The real nightmare seems to be fixing those ribs hidden underneath the scapula, ribs 2 through 5 posteriorly. Why is that so technically demanding?
It's purely an access problem. Rib plating systems require you to see the fracture clearly and drill holes for screws perpendicular to the bone surface. But ribs 2, 3, 4, and sometimes 5 posteriorly are almost completely covered by the scapula. You simply can't get direct line of sight or instrument access easily. The surgeon has to actively work around the scapula. This often involves an assistant maximally retracting the shoulder girdle, rotating the scapula out of the way by manipulating the patient's arm throughout the procedure. Even then, it's tough. Often, specialized right-angle drills and screwdrivers are needed. Or sometimes surgeons use specialized rib clamps or clips that can be applied somewhat blindly, slid underneath the scapula and secured onto the rib segment from a distance. It's technically very challenging.
Are there new techniques on the horizon to try and overcome this scapular problem and make fixation less invasive overall?
Yes, there's definitely research and development in this area. One promising avenue is investigating internally placed plates that could potentially be secured using a totally thoracoscopic VATS approach. The idea would be to access the chest cavity minimally invasively, identify the fractured ribs from the inside, and fix them with plates secured to the inner surface of the ribs, avoiding any major external muscle dissection. If this becomes reliable and effective, it could potentially solve the scapula access problem entirely and significantly reduce the morbidity associated with large open fixation procedures, especially for those difficult posterior fractures. It's an exciting area to watch.
So we've really covered a massive amount of ground here, achieved, I think, a level of synthesis that connects the very beginnings of embryology right through to the most advanced trauma stabilization and cardiac access techniques. We've gone from the separate bone centers in the sternum and the 4 parts of the diaphragm's origin, all the way to the complex plumbing of the left-sided veins and those intricate muscle-sparing approaches for thoracotomy.
Absolutely. And the recurrent theme, the consistent takeaway for achieving that elite level of understanding has to be the absolute necessity for anatomical precision and awareness of variation. Mastery in the thorax isn't just knowing the textbook picture. It's understanding why CT findings might differ from the old landmarks, or knowing the common and uncommon patterns of venous drainage, or appreciating how pathology like cardiac enlargement fundamentally changes the surgical danger zones. We saw how even a simple rule like go above the rib for a chest drain breaks down posteriorly, leaving that neurovascular bundle dangerously exposed. It's that constant awareness of the proximity of vital structures, pleura, nerves, vessels, heart, that prevents disaster.
Which brings us perfectly back to that fascinating split innervation of the diaphragm we discussed. Motor supply purely from C3, 4, 5 via the phrenic nerve, but sensory supply split. Central part by the phrenic, peripheral part by the lower intercostal nerves. So here's a final thought to mull over. Consider a patient with severe blunt trauma, multiple lower rib fractures on one side, maybe a diaphragmatic contusion or even a small tear. They're experiencing significant pain, especially with breathing that pleuritic type pain. How does knowing this differential sensory innervation specifically guide your pain management strategy? If you perform, say, an intercostal nerve block targeting the nerves from the broken ribs, what pain are you likely treating effectively and what pain might persist, requiring a different approach? How does this detailed anatomy dictate multimodal pain therapy?